Welcome back to The Explainer. Okay, today we're diving into a real medical detective story, pediatric genital urinary dysfunction. When it comes to kids, their kidneys and urinary tracts, they don't exactly give us flashing neon warning signs when something's going wrong. Instead, they leave these little clues. It takes some serious investigation, sharp assessment skills, and really a solid understanding of how these systems develop over time to figure out what's going on. So let's jump right in. Here's our roadmap for today. First, we'll cover the foundation of kidney function and assessment. Next, we'll look at the clues, specifically age-dependent manifestations. Then we'll move into the investigation with labs and imaging. After that, we'll tackle the crisis of UTIs and acute kidney injury. And finally, the solution, care management. All right, starting off with section 1, the foundation of kidney function and assessment. Okay, let's dive into this. Before we can figure out what's broken, we really need to know what a working system looks like, right? Take a look at the incredible, intricate structure of the kidney here, down to the cortex, the medulla, and those tiny individual nephrons. The kidneys are basically the ultimate regulators of the human body. They're totally responsible for maintaining fluid balance, keeping our acid-base levels in check, and filtering out all that waste. When this intricate machinery gets compromised, whether that's from an infection, poor perfusion, or maybe an anatomical defect, the entire body's equilibrium is just completely thrown off. So, where does our investigation actually begin? Right at the bedside. Honestly, before we ever order a scan or draw a single drop of blood, our absolute most powerful tools are a thorough physical exam, a super detailed history, and just keen observation of symptoms. We really need to look closely at intake and output and meticulously monitor blood pressure. Remember, BP is directly controlled by the kidneys through the renin-angiotensin system, so it's a massive clue. Now, I want you to really notice this number, 0.5. That is 0.5 milliliters per kilogram per hour. For adolescents, this is a totally crucial baseline metric for normal urine output. It's a must-know. To calculate it, you just take the total amount of output, divide it by the patient's weight in kilos, and then divide that by the time in hours. If a patient is falling grossly under this output, well, a massive red flag should go up that their kidney function is seriously impaired. But here's where the medical detective work gets kind of tricky. Moving on to section 2, the clues, and how manifestations are completely age-dependent. The thing we always have to remember is that kids are not just miniature adults. Their symptoms change dramatically depending on their developmental age. Just look at the two ends of the spectrum we have here. In the neonatal period, the clues are incredibly subtle. They're super nonspecific. Poor feeding, vomiting, rapid respiration, maybe failure to gain weight. You might not immediately think kidney issues when a baby is breathing fast, right? But jump over to an older child and the clues become way more localized and obvious. You might see facial swelling, blood in the urine, extreme fatigue, or sudden enuresis. This crucial point is perfectly illustrated by this quote from our source material. A complaint of urinaceous has greater significance at 8 years old than at 4 years old. You literally always have to anchor to the developmental age to figure out what a symptom means. Think about it. A 4-year-old wetting the bed might just be a totally normal part of growing up. But an 8-year-old who suddenly starts having enuresis, that tells a completely different clinical story. It absolutely warrants an immediate genitourinary evaluation. So once we spot those bedside clues, how do we confirm our suspicions? That brings us to section 3, the investigation, where we break out the labs and imaging. Our essential lab toolkit starts with a routine urinalysis. Honestly, this is arguably the single most important test for initial detection. But when we need to get specific about actual kidney function, we bring in the heavy hitters, blood urea nitrogen, or BUN, and creatinine. Creatinine is especially useful for estimating the glomerular filtration rate, or GFR. Why? Because it's a substance that's freely filtered right by the glomerulus. We'll actually often collect a 12 or 24-hour urine specimen just to measure this clearance as accurately as possible. And this brilliantly illustrates what happens when we need to see the physical structures. We use specific radiologic tests to reach very specific goals. For instance, a KUB, that's a plain film of the kidneys, ureters, and bladder, is fantastic for hunting down calcium-containing stones. A renal ultrasound, on the other hand, lets us safely map out the renal parenchyma and pelvis without zapping the kid with any external radiation. Super important. And then there's the VCU, or voiding cyst urethography. That uses a contrast medium to outline the bladder and show us if there's any abnormal reflux happening during voiding. Knowing exactly how to investigate is absolutely vital, because as you'll see, these conditions can escalate really, really fast. Which leads us straight into section 4, the crisis.
focusing on UTIs and acute kidney injury.
So, urinary tract infections are incredibly common. We're talking an overall prevalence of about 7% in infants and young children. But why is that? Well, anatomy plays a massive role here. A short urethra basically gives bacteria an easy, direct entry point. Uncircumcised males under 3 months old and females under 12 months old actually have the highest baseline prevalence. Now, it usually starts as a localized infection, sure, but if it's left unchecked or if there are underlying structural issues involved, man, it can lead to some severe systemic complications.
Which leads us to a pretty critical question. How do we manage these sudden, life-threatening renal crises? I'm talking about acute kidney injury, or AKI. This is when the kidneys just suddenly, completely lose their ability to regulate urine volume and composition based on fluid intake and what the body needs. It's a real emergency.
To really grasp the severity of renal failure here, we have to clearly differentiate between two easily confused terms, azotemia and uremia. Azotemia is the accumulation of nitrogenous waste in the blood. It's a clear sign of impaired filtration, which you'll often see as elevated BUN and creatinine, but it isn't inherently life-threatening just on its own. Uremia, though. Uremia is a much more advanced condition. This is where the retention of those toxic nitrogenous products produces really dangerous symptoms that start involving multiple other body systems. Uremia is a full-blown, life-threatening crisis. So the big question is, how do we bring a patient back from the brink of that crisis?
Let's find out in Section 5, the solution and our care management strategies.
Managing acute kidney injury takes some very strict, rigorous steps. Step 1, we absolutely must treat the underlying cause. In kids, that's most commonly poor renal perfusion from severe dehydration. So we start by urgently restoring that volume. Step 2, we insert a Foley catheter. We have to do this to rule out urine retention and to meticulously monitor their exact output. And step 3, this is the big one. During the oliguric phase, where their urine output plummets, we must maintain zero water balance. That means the exogenous water we're giving them cannot exceed the amount needed to replace their endogenous water formation and those insensible losses, like what they lose through sweat and respiration.
Now, you might think our most advanced, expensive hospital tech is the best way to monitor all this fluid balance, right? Well, surprisingly, a simple record of daily weight is actually the most useful means for assessing it. Despite all our modern gadgets, meticulous attention to daily weights, strictly measuring every drop of intake and output, and continuous blood pressure monitoring, these are literally the most powerful tools in nursing care management for these patients.
Finally, solving these complex GU cases is never, ever a solo job. It takes a highly dedicated interprofessional care team. We're talking the primary care provider, the renal MD or nephrologist, physical therapy, occupational therapy, and of course, the registered nurse. The RN is so often right at the center of it all, managing those strict fluid protocols, prepping the child for all these tests, and providing absolutely crucial education to the family.
And that brings us to the end of our investigation today. Before we wrap up, I want to leave you with one final provocative thought. As medical detectives, what vital, age-dependent clue might you be missing in your very next pediatric assessment? Remember, a symptoms meaning completely changes as a child grows. So stay curious, stay vigilant, and always trust your foundational bedside assessments. Thanks so much for joining me on this explainer, and I'll catch you next time.